So thanks Rohit for this lovely course which is jam-packed. I think it's because of people like Rohit and David Chang there. Now let's look at this patient here. Somebody had implanted a lens, PC rupture, left the lens behind. Years later, the patient has come to me. The problem was this guy was a big shot in the garment. Okay. Now what I told him was, you can see the lens is subluxed. Sombering rings are present. So I told him, no problem, I'll make you all right. So let's ask the panel, and whenever I tell a patient like this, I'll make him all right, you can imagine how bad it will go. So panel, let's ask David perhaps, who is our guest here. David, we have a patient there with sombering rings present. So question comes, there is no capsule obviously there, there's posterior capsule is gone. That lens is badly subluxed. How do I remove those sombering rings now?
Yeah, so I mean, this would be a great case to just suture the haptics to the iris as one option, but when you have the sombering ring that's that big, that'll get in the way. So you do have to try to strip it off, and you know, Sun Pek Chi has a beautiful technique where she uses an empty IOL cartridge, and if you pressurize the globe with viscoelastic, it's just everything wants to exit through that exit pipe, and that might be useful in this type of case.
But that can happen only if you have a support behind.
Yeah, that's right.
So Rohit, anything you can?
Sombering ring are the basic culprit in this, so those have to be managed. So if you manage them, then you know, the centering would be.
So let's see what we do. You see, this is a large eye, and a trick I tell everyone here is, when you have a large eye, do a small peripheral iridectomy. The reason is, you can come more anterior when you make your sclerotomy. Now look at that IOL, it is stuck to the iris also, because I told you this has happened some years later. Now I have dislodged that haptic from the iris slowly using the handshake technique. Now my game plan is very simple. I need to create a scaffold. So if I create a scaffold, then I can remove the sombering ring, because the sombering ring will not fall down. So now look what I'm doing. I'm now going to do a handshake technique, and I'm bringing that IOL from above the iris to behind the iris. So you see, one haptic is out. Now I'm going to do the second haptic. So whenever you have sombering ring where there is no capsule, remember, I need a scaffold there. But where will I put the scaffold? Unless you do a Yamane or a glued IOL, you can't do it, because you have to go behind the sombering ring. So now I'm doing the second haptic. Once I catch my second haptic, look at the tip, catch the tip and bring it out. So this is the glued IOL scaffold. Now once I have a scaffold, I'm tucking it into the chariot's pocket. Now I can attack the sombering ring. So the principle, if you see on the animation, is like this. I made my flaps. I'm going to implant my IOL inside. This is, I'm talking of cases, remember, there is no capsule there, but sombering rings are there. So there is no posterior capsule in the central area there. Now I have a chance to remove the sombering rings without them falling down, because please understand, these cannot come out with vitrectomy probe. Now you see I'm breaking the additions of the sombering ring from the periphery, bringing them to the center. Now you can use, as David Chang said, Sue's technique, or use a phaco probe, or just burp them out. Choice is yours. So here you can see, now once I have done that, I'm now trying to bring the sombering ring in front of the IOL. Once they are in front of the IOL, now you see my life will become much easier, because I can now go in with the phaco probe and emulsify them. So this is the way I would suggest to manage sombering rings. See how many sombering rings there are. They are large, they are thick. You don't want them falling down. So this is the best thing. And I was so happy at seeing this case. And you know, whenever I'm happy like this, things don't go out well. So anyway, I try to complete this case as best as I can. And obviously the pupil is dilated. So we wanted to close it up with the fourth row pupilloplasty. Those who haven't done that, a very simple technique you can use, where you pass the needle straight in. From the other side, a 26 or 30 gauge needle, railroad the two, bring it out, 4 throws, and it's game, set, and match. So here you can see I'm doing this. Remember, there are two ways to do this. It's important for you to know. I'm doing a vertical 4th row pupiloplasty. If you have an iris prolapse, do a vertical. You can do horizontal also in an iris prolapse. Let's say an IFIS case which David showed us on IFIS. But in this case, do always a vertical. Because if you do a horizontal, it will just bunch up. Anyway, coming back to this case, I thought use a vitrectomy probe. See the Purkinje image. That should be bang centered. And look at that Purkinje image. Don't look at the inverted Purkinje image. That is P4. Don't focus on that. Focus on the P1. Now, patient done. Very happy. And I was telling my wife, oh, I am so good. Post-op 1 week. I told you this is a big shot. Believe me, a real big shot he was. When working in the garment, 2/60. And then I realized the mistake. I had to change the IOL also. If you see in the beginning, the IOL power was wrong with the surgeon had put. I just missed that, and I had to explant that IOL and put a new IOL. I use the same IOL. Now I had to sit for 1 hour explaining to the patient my mistake. And he said, why you made this mistake? Huh? I've come to you. Why you making these mistakes? Huh? Huh? So now what am I to tell him? I have to keep quiet only, Baba. So anyway, now question comes, what to do, Rohit? What about you, Gaurav? The power was too much for me to do a laser on him, okay? The cornea is not that thick enough for me to do the laser. So, Gaurav?
Yeah, so you'll have to go for an IOL exchange, sir,
Yeah.
I think. There's no other choice.
So that's the only way I could do it is, but Kumar, there's a small problem here. I already have created a small pupil. Now, what would I do? Kumar?
Refer to AMAR.
So now I have dislodged the haptics. This is just 1 week post-op, okay? And now I've dislodged the haptics. Now my problem is I take a scissor and I'm cutting this pupil. So I've enlarged it because I know I have to take it out. Now look what's happened to that haptic. It's got stuck in the iridectomy there. I'd created a peripheral iridectomy, remember there? So it's got stuck there. So I had to dislodge it. Now slowly take it out. Fix a new glued IOL. So again handshake technique. Now remember again I have to do pupilloplasty at the end of it also. So now I'm just fixing it back, fix the tuck. Now I have to close back. Now since I've got a cut here, I might as well do a horizontal 4th row pupilloplasty. See my Purkinje image, close it, and this is the iridectomy as you can see here. Look at the pre-op, look at the post-op, and you can see here 1 week post-op vision was 2/60. Then 10 days post-op vision improved to 6/12. I'll just show one last case also after this. And you see here in this particular case, this is the patient who had come to me. And why I'm trying to show you this case is, see this. Look at the HOA. And I tell everyone, start seeing the HOA of patients. Look at the holiday pentacam report. You'll see 6.358. Basically, it's a very high HOA. A normal HOA is 0.3. Now, the patient has a scar right in the center. The question comes, now how do you manage it? There's no capsule worth the name obviously there. Normally, we'll say go for a penetrating keratoplasty. And what we have started doing is cases like these, where you have scars, where you have even opacities, and I'm showing central scarring, which peripheral is easy. I'm trying to avoid a penetrating keratoplasty. So once I have made my scleral flaps, obviously I'll need to fix an IOL in this case. But in this case, what I wanted to show you here is, look at the peripheral iridectomy which I'm doing there. Once I have done that, I now go in, make my sclerotomy on either side. Once that's done, I will fix the glued IOL. Here you can see now, I've done the vitrectomy, I've got fluid going inside the eye. I make my main port, apply my vitrectomy probe there, and once that's done, see the haptic coming out. Once the haptic is caught, wait for it to unfold, pull it out. Now look at the handshake technique going inside, transfer the haptic from one hand to the other, bring it out, and you can see the second haptic coming out. The issue here in this case, why I wanted to show you is not to show only the glued IOL, but now look at the next step which I'm going to show you, and how do you manage this case, and how to avoid the penetrating keratoplasty in this case. So now you see I'm just going to rotate the trolley of the patient so that I can be comfortable. Now look, I'm going to start the single pass 4th row pupilloplasty. The advantage of the 4th row game is it's very easy. You can keep on repeating it as many times as you want. But the idea is simple. I need to make a 1.5 millimeter pupil. A simple rule you can follow is, we have designed also a holiday pinhole device. So keep it in front of the patient, made by Epsilon. What we do with the help of Jack Holiday, we made that. Keep it in front of the patient, ask him which pupil he likes. If he likes 1, we'll make the pupil 1. If he likes 1.5, we'll make it 1.5. But look at what I'm doing. As I'm doing slowly, you'll notice this pupil is becoming smaller and smaller. That small peripheral iridectomy is increasing, and if needed, I can even close that. Look at the endolimiter trick, which I'm going to show you from outside, which helps me see better. As you can see, the pupil becoming smaller and smaller. Now, remember the step here is you need to have a vitrectomy probe. All your phaco machines have got very good vitrectomy probes. I tend to use the posterior vitrectomy system, being a retina person, but you can always use your phaco vitrectomy machines also with it. That small peripheral iridectomy had become large because I have pulled on that iris. That also gets closed because I don't want this patient to have any polychoria, things like that. Once that's done, now look what I'm going to do. I'm going to check the haptics. Once the haptics are in place, then take the vitrectomy probe. And you can see there, with the vitrectomy probe, decide and see whether you need to make that pupil correct size or not. It has to be centered around the Purkinje image, and you can see it's approximately in the Purkinje image there. Once that's done, I now close this patient down. Question comes, how did this patient behave? So the idea of this video was to show you, in cases like these bad cuts, which you will see there, injuries, etc., you can do the glued IOL, followed by the pinhole pupiloplasty, as I'm showing here. And look at this patient here. Pre-op, post-op 1 week, patient improved immediately to 612. That is just to show you a coaxial photo of the same case. Thank you very much, Rohit, and thank you, ladies and gentlemen.
Dr. Gaurav, can you set up? How do you see fundus in such patients, and if required?
So basically, you can see the fundus 160 degrees plus of the fundus with either use the Mirante from Nidec, you use the Zeiss is there, the Optos is there, and the Heidelberg is there. These are all laser scanning ophthalmoscope, which will give you a fantastic picture. But let's give a theoretical example. 5 years post-op, this patient developed a retinal detachment. I'm just giving it as theoretical. All you need to do is take a YAG laser and shoot, make that pupil bigger, and you're back to treating that patient retinal detachment even. One thing remember, these are young patients who have come, let's say, to us with an injury. The chances of success, and these cuts have also a lot of corneal vascularization. So doing a penetrating keratoplasty has its own headaches and its own problems. Even let's say if I had done a PK, without doing a pinhole, that patient's vision is not going to be exactly bang on track.